Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello, and welcome to the latest episode of the POMA Does podcast series, sponsored by the Pennsylvania Osteopathic Medical Association. I'm Syed Arian, and I'm an intern at the Lehigh Valley Health Network Family Medicine Practice in Schuylkill County, Pennsylvania. I am a recent grad from the Philadelphia College of Osteopathic Medicine in Philadelphia. Today, we're going to provide an overview of RSV and influenza in our pregnant and pediatric patient populations. We'll discuss these two viruses, symptoms patients may experience, special considerations for a pregnant patient and pediatric patients, available immunizations to help protect against severe infection, and what we as physicians can do to best care for our patients. This podcast episode is eligible for CME credit. To claim your credit, visit the webpage noted in this episode's description or visit the POMA Does podcast page on the POMA website. This podcast episode is supported by a grant from the American Osteopathic Association. The Pennsylvania Osteopathic Medical Association, along with other osteopathic state and specialty associations, have collaborated with the AOA to provide education to physicians and their patients regarding public health concerns such as RSV, influenza, and COVID. This podcast episode was developed entirely by POMA. None of the panelists or planners for this episode have any conflicts of interest to disclose. I'm privileged today to be joined by Dr. Angela Zawissa and Dr. Susan Medali. I'd like to start by asking each of you to briefly share your reason for selecting this topic.
Hi, everyone. I'm Dr. Angela Zawissa, as Dr. Arian mentioned. I work as a pediatric hospitalist for Lehigh Valley Health Network at the Schuylkill campus in Pottsville, Pennsylvania. I work with the newborns in the newborn nursery, and I also cover the pediatric floors in my hospitalist role.
I'm Dr. Susan Medali. I'm core faculty for the Schuylkill Family Medicine Residency and Lehigh Valley Health here in Pottsville, PA. I work in conjunction with Dr. Zawissa and Dr. Arian and do a combination of family medicine, OBGYN, as well as some of the inpatient pediatrics and newborn nursery.
She wears a lot of hats.
So these topics are very near and dear to our hearts because these are things that we're talking to our patients about, especially because the three of us see our patients all different ages and in different settings. And if our goal can be to prevent RSV and flu from making it into the hospital, we can make Dr. Zawissa's job easier and also keep a little bit of work away from us and keep our patients happy and healthy.
Thank you for sharing your inspirations for today's podcast. We'll jump right in and start with RSV, or respiratory syncytial virus in children. So can we talk first about what it is, when it was first identified, and some history behind the virus?
Sure. RSV has been around for several decades. Testing has become much more prominent over the last several years, last couple of decades probably. Especially it is increasingly being identified as a major factor in bronchiolitis in children, and especially associated with a majority of hospitalizations, especially for bronchiolitis in the winter months, typically speaking November through March at the latest. So the typical peak season pre-COVID was typically peaked in about February of each year. Since COVID, we're still kind of getting our bearings into how the epidemiology has changed a little bit. I think this year we're seeing the peaks a little bit earlier. I'm still seeing a lot of RSV in the hospitalized patients, but my own personal experience has been more of a peak in November and December, and I'm hearing that from other colleagues as well. So it does primarily affect infants, under the age of 12 months, although we do see some hospitalizations in children with underlying comorbidities, asthma being the most common one of those. Also, congenital heart defects and underlying neuromuscular disorders would be other common comorbidities to increase your risk for hospitalization in the pediatric patient.
All right. And what are some of the symptoms that providers and parents can look out for, and how does it generally affect the healthy population?
Sure. So typically speaking, it starts off as your usual respiratory infections, nasal congestion and rhinorrhea, a cough. You will see a fever in these patients, usually on the milder side of fever in the 100, 101 range. And then the hallmark that differentiates bronchiolitis from, just your regular upper respiratory infections is the presence of wheezing and also increased respiratory effort. So in these patients, you'll be able to auscultate wheezing, obviously, and then you might also see increased work of breathing, most notably tachypnea. The specific rate for tachypnea depends upon the child's age, but for infants, a respiratory rate in the 40s and 50s and above would be considered to be tachypnic. You might also see belly breathing. And what I described to my residents is that increased work of breathing starts with tachypnea and then belly breathing and then works its way from the belly up to the head. So then after belly breathing, you would see retractions, mild retractions, maybe just subcostally, and then the intercostal retractions, supraclavicular retractions, and then later signs of respiratory distress in this patient population do include tracheal tugging, nasal flaring, and also grunting. Those are the hallmarks, the symptoms of RSV and bronchiolitis in general. RSV is just one of the many viruses that can cause bronchiolitis in this patient population.
All right. And what pediatric populations are at risk? I know we briefly mentioned asthma as being a comorbid condition, but what others and how does RSV affect those more at-risk populations?
Sure. So those at-risk populations are affected because of their risk for more severe disease is much higher, and therefore their risk for hospitalization is much higher. Any patient with any past medical history would potentially be at a higher risk for complications from bronchiolitis and RSV, but most notably, you're looking at your premature infants, those with chronic lung disease or bronchopulmonary dysplasia, congenital heart defects, asthma, underlying neuromuscular disorders, cystic fibrosis, anything that would affect the lungs or the heart would automatically place you at increased risk.
All right. And what treatments and preventative measures do we have for these patients?
So up until recently, we really didn't have much in the way of preventative measures. But first going to treatments, the mainstay of treatment for RSV is supportive care. If from an outpatient perspective, you want to talk to your parents about a cool mist humidifier, we always say cool mist because if an older sibling would get into a warm mist humidifier, then you're talking about treating, scald burns instead of just bronchiolitis. And we want to avoid that as much as possible. So a cool mist humidifier, nasal suctioning, whether it be with a bulb syringe, a nose freed is a particular brand that I'm aware of, but I believe there's other brands out there that involve a mucus trap and using the parent's mouth as a suction if they're so inclined to do so. Keeping the patient comfortable with some Tylenol and, just lots of fluids, making sure that their child stays well hydrated and advising the patients to watch for signs of increased work of breathing, like we already talked about. One of the most important things I personally believe in treating more the parents than the patients in this particular situation is managing expectations. So these viruses and RSV in particular don't typically get the worst that they're going to get until day 5 of the illness. So understandably, you have a mom of a 2-month-old, who develops cough and congestion. She's very worried about that child. She brings him in on day 1 of symptoms. Provide reassurance, do all the usual stuff that you do. And then 2 days later, she's calling because he's not any better. And then 2 days later, she's calling because he's still not any better. Warning the families that their child will not really hit the peak of their symptoms until day 5, I think puts a lot of parents at ease as to what to expect and when they have to worry, when they don't have to worry. But again, lots of fluids, making sure that they're not in any respiratory distress, and then the comfort measures with the humidifier, nasal suctioning, and acetaminophen if needed. In terms of preventative measures, the main preventative measure that we had was something called Contagious. That is the brand name. It provides passive immunity, and it provides passive immunity for approximately 1 month at a time. So typical administration was given once a month for the peak months of RSV season. So a total of 5 or 6 doses throughout the RSV season. And over the years, the guidelines for providing Contagious for the at-risk population really narrowed down. Guidelines include infants less than 29 weeks, infants less than 32 weeks, but who are still requiring oxygen, those with congenital heart defects. Most recently, and this is the first season, RSV season that we've had, this particular immunotherapy, it's called Beyfortus or nirsevimab. It provides passive immunity for approximately 5 months. So it's a one-time dose given at the beginning of RSV season, and then it should provide immunity throughout the entire RSV season. Now, this is passive immunity. You're actually providing the patient with the antibodies to fight the infection. As with other vaccines, an antigen that then allows the patient to develop their own antibodies. Therefore, it's passive immunity. It is given to infants who are 8 months of age or less entering their first RSV season. As Dr. Mandali will talk about later, there is a version available to give to pregnant mothers. You do not have to give this Beyfortus if the mother did receive the RSV vaccine more than 2 weeks before delivery. It can be given early in life, even in the nursery. We are not currently doing that at our hospital right now. We're sort of piloting it at the larger campus of our institution, and then they'll work out the kinks and everything like that, and then it'll be rolled out to the other sites within the system. So it does decrease your risk for severe RSV by about 80%. Now, similar to the influenza vaccine that we'll talk about here in a minute, it does not completely negate your risk for developing RSV or becoming sick with RSV. It simply decreases your risk for severe RSV and therefore, hopefully, your risk for hospitalization from symptoms. The dose currently is 50 milligrams for infants that weigh less than 5 kilograms and 100 milligrams for infants that weigh more than 5 kilograms. There was a shortage of the 100 milligram dose. They were selecting which patients would receive the vaccine, the immunotherapy, trying to reserve it for the more severe or more at-risk patients. They did not recommend giving 250 milligram doses to make up 100 milligrams. But that's Beyfortus. We're all anxiously awaiting to see how this first year goes, with it being FDA approved for the first time this year, and seeing how it affects RSV season in the next couple of years.
Wonderful. And as a parent of a 9-year-old and a 4-year-old, I really appreciate the fact of, setting expectations. I can, hear a cough or two and already think about running down to the urgent care. So I hear and feel those parents who come in with, anxiety and are worried about how their children are presenting. So for the parents who are thinking about getting this vaccine for their children, what are some of the risk factors? I know we talked about a lot of the benefits. What are some of the risk factors that we can talk to parents about?
There have not been a lot of major side effects or adverse reactions identified. The ones that we typically see go along with what you might usually see at your quote-unquote routine immunizations now. Redness or swelling at the ejection site. This does not typically provide fever because your body is not developing its own antibodies. There's always a risk of anaphylaxis with any sort of medication or anything injected into your body, but those risks are incredibly low at this point in time.
Thank you, Dr. Zoissa. And now we are going to switch gears and talk about the RSV vaccination in pregnant mothers. And I believe, as Dr. Zoissa briefly mentioned, there may be some limitation to the supply of vaccines in children. And that may be one of the things we recommend mothers to get the vaccination for. So, Dr. Medali, can you talk to us about some of the other benefits of vaccinating during pregnancy?
Yeah, so in addition to having the good fortune of having the new RSV prevention vaccine for kids, which has been a little bit hard to come by this year, we are fortunate to have had some in the community and have had given to kids. And anecdotally, the kids have done very well with little to no side effect despite being very young. The best thing that we can do right now is to prevent needing to vaccinate our kids. So we are lucky enough that this year there were 2 RSV vaccines that were released for the adult population, one of which is made by Pfizer and is called Abrizio and has also been approved by the CDC to be given to pregnant patients. So there's a little bit of a time range for this vaccine. It needs to be given between 32 weeks pregnant and 36 and 6 weeks pregnant. And that is because, as Dr. Zoissa mentioned, it takes at least 2 weeks for the body to produce enough antibody to be able to pass that to the fetus, but will protect the fetus for at least 6 months after delivery. So currently, this is a vaccine in which the body does produce antibodies to the RSV virus, and that can help to prevent both the RSV virus in the mother as well as pass that to the fetus for at least 6 months. It is that narrow time range, which has been a little bit difficult for some patients because you don't have that many office visits necessarily, and some of our patients have had to seek that out. The other restriction is that we are currently only giving this vaccine from September to the end of January. And that's because we know that is our time range when these babies are going to be born. And as Dr. Zoissa mentioned, this is really the peak of the RSV season. It doesn't make as much sense to vaccinate for it later in the summer months when it's not likely to be around, at least not in such high quantities that we're seeing currently. So it has been approved by both the American College of OBGYNs and the CDC to be given from September to January in our patients 32 to 36 and 6 weeks. And it is only the one of the 2 adult RSV vaccines that is currently recommended in pregnancy. We will have to wait and see for the next RSV season whether we have both vaccines approved for pregnancy or if it will remain just the one. And hopefully we will be able to vaccinate all of our pregnant patients next RSV season.
Awesome. I'm glad some of those options are in place for expecting mothers. And now we are going to talk about influenza. I know it's been around a long time and is probably good to combine it with our talks on RSV due to the upper respiratory symptoms and maybe delineating between the symptoms of flu and RSV. But Dr. Zawissa, if I can first ask you about a general overview of influenza, the nature of how the strains change, and the pediatric population that are at greatest risk.
So everyone knows that the influenza virus has been around a very long time. I was fortunate enough to be in residency during the swine flu epidemic, and I know for sure that there was an epidemic in 1918 as well, and there was an epidemic somewhere in the middle there that I'm blanking on right now. But influenza has been around for a very long time. The strains, the common strains, are the strains that are most prevalent, do change from year to year. So that's why the influenza vaccine, which I can talk more about in a minute, does also change from year to year. It's basically a scientific prediction as to which strains will be most popular and then providing immunity against those strains. Symptoms of influenza can be similar to RSV, cough, fever, nasal congestion, rhinorrhea. You can develop bronchiolitis, specifically with the wheezing and the increased work of breathing from the influenza virus. RSV just happens to be most common in terms of specific bronchiolitis symptoms. The fevers with influenza do tend to be higher, and in these patients, you are more likely to see vomiting and diarrhea in addition to the respiratory symptoms. In my own anecdotal experience, kids with influenza just tend to be miserable. Yes, RSV, you're congested, you can't breathe, but, you might be a little bit fussy or irritable, that sort of thing. But you don't just get like the absolute miserable kids like you do with influenza. So that's the biggest difference that I've seen in terms of RSV versus influenza.
All right. Thank you for that overview. And in the pediatric population, who should get the flu shot?
Everyone should get the flu shot unless there is an absolute contraindication to do so. The most common possibility being a true anaphylactic reaction to the influenza vaccine in the past. So really, there are not many situations where you should not get the influenza vaccine. You can get it starting at 6 months of age. So our oldest child was born in September, at the end of September. So he turned 6 months old at the end of March, right when an influenza season was ending. And he still got his first flu shot when he was 6 months old, just because my husband's also a physician. We are that passionate about protecting our children against influenza. So after that initial season, it can be given every year, usually starting in September or October, and can be given all throughout influenza season. Again, also it kind of stinks sometimes being the children of doctors. My husband usually brings home some influenza vaccine from his office, and we have a rousing Friday night at the Zawissa house giving flu shots to all of our kids. So they know to anticipate it at this point in time, and have even participated in giving the vaccine to my husband and I as well over the years. So
two of the things that go along with that are that for the first year ever, the CDC has said that an egg allergy is no longer a contraindication to the flu vaccine at any age and in any type. So for a doctor who's longest patient has a severe egg allergy, we've been giving her, the egg-free vaccine, which has been hard to find until this year, and she did fantastic. And then the other piece that it took me a long time to learn is that under the age of 7, the first year you get your influenza vaccine, you need 2 doses that first year. So I like to make sure that I add that in so that my residents don't take as long to figure that one out as it took me well into my 2nd or 3rd year of residency to realize that was happening.
Yes, it can be hard to remember. And the age for that changes. It used to be 9. If you were first getting vaccinated for the influenza, age 9 or less, you got 2 doses, and now it's less than 7. So yes. So I did forget that important piece of information. So thanks, Dr. Medali, for bringing that up.
All right. And Dr. Medali, as far as the influenza vaccination goes for expecting mothers, where during their antepartum course should they get the the influenza shot? And are the indications similar to the RSV?
Yes. In pregnancy, as opposed to with the RSV vaccine, the influenza vaccine can be given at any time during pregnancy, because not only do we have that great passive immunity to the fetus, to the unborn baby, but we also are protecting mom against influenza. So influenza in pregnancy can be even more miserable than those poor kids being sick with flu. As kids, the body aches, the high fevers, dehydration, decreased ability to breathe. And during pregnancy, baby has a tendency to push up on the lungs and make it hard to breathe anyway, but can be even more so worse during having the flu. So the only change for pregnancy is that there is only recommended the inactive or the attenuated vaccine. So the only flu vaccine we don't recommend in pregnancy is the nasal mist, which has become less popular and harder to get anyway. The other nice thing is that you can get the flu vaccine, the RSV vaccine, the COVID vaccine, or the tetanus and pertussis vaccine that we also recommend in pregnancy all at the same time. So there's no need to wait between appointments for the flu shot versus the RSV, no need to choose between them. Both can be given at the same time if they're in that time range. But again, you don't have to wait for any particular point in pregnancy to get the flu shot.
Yeah, I definitely remember, like I said, I had the privilege, so to speak, of being in residency during the H1N1 epidemic, and I was in the NICU during one of those months and still have flashbacks from that particular rotation at that particular time. We had several moms with complications of the H1N1 and delivering their babies prematurely as a result. So again, that was during an epidemic, but it's still important to get your influenza vaccine to not only protect pregnant mothers, but protect their babies as well.
Absolutely.
Okay, well, I'd like to thank each of you for your time and, in summary, discussing RSV, its history, some of the symptoms that us providers and parents we can see, as well as the pediatric populations that are at risk, the treatments and preventative measures, including the RSV vaccination, as well as how RSV and influenza affect pregnant mothers and the indications and timing of the vaccinations. As a reminder, this episode is eligible for CME credit. To claim credits, visit the webpage noted in this episode's description or visit the POMA Does podcast page on the POMA website. Thanks again and stay healthy.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.